Hey folks, my name is Beth Wright and I'm providing you a podcast on chapter 54 for the elimination unit in your NUR 205 nursing med-surg class. This podcast is regarding the management of patients with kidney disorders, and we're primarily going to be talking about renal failure. So just starting off with the talking about kidney disease, we first have to think about, obviously, our fluid and electrolytes, because the kidneys are what helps keep all of that balanced. And so I know how much students love fluid and electrolytes, and it is really going to be coming at you in this unit as well as several units in 205. So be sure to, you know, know and go back and review your fluid and electrolytes from where you had it last spring. All right, so our most accurate indicator of fluid loss or gain is weight. And so, that can tell us a lot. It's important to look at weights, look at trends in weights. What was the patient when what did they weigh when they entered into the hospital versus what do they weigh now? Do we have a fluctuation? Are we retaining fluid? Are we losing fluid? So that can tell us about fluid loss and gain for sure. And if you look in your textbook on table 54-1, it'll give you several labs and things, signs and symptoms to look for. And so that's, going to be important for you to take a look at that. And it should be fairly familiar to you. So be sure to take a look at that. Now, when we talk about kidney failure, that results when the kidneys cannot get rid of the waste in the body or perform those regulatory functions that the kidneys do. So obviously what's going to be important here, folks, is that you understand the whole anatomy and physiology of the kidney. That's going to be very, very crucial for you to know that. And so if it's been a while since you've had that, and I guess probably it has, will want to go back and do a really, really good review of that anatomy and physiology of that. When we have renal failure, it's systemic disorders that results from many different causes. And you can have acute renal failure. It's also known as renal injury, acute renal injury, uh, typically reversible. But that results in a decrease in that glomerular filtration rate. So the very important part of the kidney is your glomerulus, because it's where that whole filtration uh, process occurs, where it's holding on to important things to reabsorb back into the body and letting go of things for excretion, secretion of waste that needs to get out of the body. And so, our glomerular filtrate rate is, one thing that we look at. When that glomerulus is damaged, then we're going to have problems with our kidneys uh, and our whole systemic system, because we're going to hold on to waste that is toxic to the body, that is poisonous to the body. We see that oliguria as well with acute renal failure, and that can be less than, sometimes you'll see 400 milliliters per day or 500 milliliters per day. Um, or there's actually a non-oliguria phase that can occur as well. And that can be a loss of greater than 800 per day. And we can also see anuria, which means less than 500 milliliters per day. and that's for adults. Now, for pediatrics, anuria is less than 1 milliliter per kilogram of a child um, per hour. Chronic renal failure leads to end-stage renal disease. It is progressive, it's irreversible, and the renal function just starts deteriorating over time and results in azotemia. And that is where azotemia is where we have urea nitrogen in the blood. And we'll also see an increase in the creatinine there. We'll see uremia again, where the urea is actually in the blood. The renal function declines, and we obviously have some serious issues there. So we're going to talk about these in greater detail, both the acute and the acute and the chronic renal failure. So let's first start off with that acute renal failure. Some causes that can happen, that can result is hypovolemia, hypotension. And of course, you know what hypovolemia is. That's when we have volume. When you look at the end of that, volemia is volume, and that's when we have a decrease in our volume of fluid in the body. So dehydration, things like that, is what causes the hypovolemia. Hypotension is where our blood pressure is very low. Um, Also reduce cardiac output and heart failure because it takes a lot of output, cardiac output, 25%, as a matter of fact, of the cardiac output is used for renal function. So we gotta, when we have a reduced cardiac output, then that's going to cause a reduced blood flow to the kidneys and cause us problems. Also, heart failure can be an issue. And any kind of obstruction of the kidney, obviously, can be a problem, both of the kidney or the lower urinary tract area. So like, tumors, kidney stones, things like that can definitely cause acute renal failure. And then obstruction of the renal arteries or the renal veins can cause acute renal failure. Causes of chronic renal failure can be diabetes, hypertension, chronic glomerular nephritis. So if you look at that word, we've got the glomerular in there, the glomerulus, and nephritis, nephrons. So nephrons are part of that structure that is the key to the whole filtration, what's helping with the absorption of the reabsorption of needed substances in the body versus the the secretion and excretion of the waste. And so when you see itis at the end of it, that's inflammation. When we have a major inflammation going on of the glomerulus and of the nephrons, then we're going to have chronic issues, and which can lead to chronic kidney failure. Pyelonephritis is basically a kidney infection. We sometimes think a lot of times people will say, oh, I got a kidney infection, when in fact it may not be a kidney infection, it could be a bladder infection, but we're going to talk in great detail about kidney infections and bladder infections in class. So, but anyway, that can lead to chronic kidney failure. Any kind of obstruction, which we mentioned with acute as well. Any kind of lesions, hereditary lesions, vascular disorders, and of course medications or toxic agents that are nephrotoxic. So those are important to know so that we can try to work towards preventing chronic or acute renal failure. So let's get into our acute first. The etiology here, and if you look in your textbook, um, on page, I'm not sure what that page number is, but and it's chapter 54. There's a chart 54-4 there that goes into these kinds of, the patho and the etiology. And so let's first talk about, there's three different types basically that can lead to acute renal failure. And we first have, the pre-renal. So if you think about the pre-renal, that results from um, conditions that interrupt the renal blood supply, which reduces the renal perfusion. And so just think before renal, okay? So it's external factors there that can lead to this and cause hypoperfusion. Um, and obviously when we have that, these kinds of conditions, we're going to have a decrease in that glomerular filtrate rate. And you'll see, look for that when you're doing clinicals, the glomerular filtrate rate. They typically do it on everybody. It's a calculation of lab uh, from the laboratory that they do typically on everybody. So be sure to take a look at that on your patients because that can tell you about how the kidneys are functioning. But reasons for the renal causes of acute renal failure could be hypovolemia, sepsis, shock, hemorrhage, burns, because with burns people lose a lot of fluid, so that makes them hypovolemic. Um, and impaired cardiac output, even diuretic therapy, because diuretics causes people to lose volume, causes them to increase the urine production, and we can overdo that sometimes with individuals, so we have to be careful about that. And of course dehydration can be a pre-renal issue as well. Now the intrarenal uh, cause is also known as intrinsic. That is, things, direct damage to that renal tissue, such as the glomerulus or the nephrons and that kind of thing. Another diagnosis you may see is acute tubular necrosis, and that is damage to those tubules of the kidneys, and they any kind of injury to the kidney, such as from a blood clot, a thrombus, or any kind of ischemia, uh, you know that can occur to the renal. It may be because of a low mean arterial pressure. That mean arterial pressure is related to your cardiac output uh, times the peripheral resistance, and it's got to be 65 millimeters of mercury, your mean arterial pressure. Um, but that it's got to be at least 65 millimeters for organs to be perfused. So anything below 65 is going to cause a problem with that renal function, that and cause damage to the kidneys. Um, Also, toxins or nephrotoxic meds such as aminoglycosides or contrast media that's used for X-ray procedures. Um, Also, immunologic processes can lead to kidney damage. And one that comes to mind there is when our immune response um, starts attacking itself, if you will, our autoimmune problems, if you will, can cause problems and damage to the kidneys. Um, and such as one that comes to mind too is like from strep throat, for instance. Strep that causes glomerular nephritis. The strep that goes untreated, it can go to the heart and it can go to the kidneys. And when it's in the kidneys, it can cause nephritis or glomerular nephritis. So, we have to watch about that. Systemic vascular disorders also can cause kidney damage, and, severe infections such as sepsis can cause severe infection. So with the intrarenal, again, we're going to have that decreased renal GFR, the glomerular filtrate rate. We're going to see a fluid and electrolyte imbalance a lot of times with this one, and a progressive azotemia. Um, Now, the third type is the postrenal type, and it's, if you think about, okay, where post means after, so after the kidneys, we can have that, can be a mechanical obstruction of urinary flow, such as kidney stones, tumors, any kind of strictures or stenosis of the vessels, uh, benign prostatic hypertrophy or hyperplasia can cause a problem about the, with the urinary flow as well. So what happens there when there's an obstruction, of course, pressure rises, resulting in a decrease in the glomerular filtration rate there. Um, so, when we think about any of these causes that causes acute renal failure, it is crucial that we get on top of what is the cause. What is the cause of our patient having acute renal failure? And let's get it turned around. Certainly if it's a stone of some type, we're going to push the fluids to try to get that stone out if it's in a place that can happen. Sometimes renal stones have to be what we refer to as blasted out. But nevertheless, we want to get that taken care of immediately. If it's a nephrotoxic drug, then we want to, get on top of that, talk with the doc, and, try to get that uh, discontinued or changed to a different drug that's not nephrotoxic. Because complications of acute renal failure are many. Dysrhythmias, our patients increase susceptibility to infection, and of course electrolyte abnormalities. They can have GI bleeds from GI being gastrointestinal, bleeds from stress, ulcers, from the whole problem here. They can have multi-organ failure. Of course, this acute renal failure can lead to chronic renal failure, and people can die from acute renal failure. So we've got to get on top of this as quickly as possible. Typically, we will see, things like the pre-renal and the post-renal are quicker to be able to resolve if it's identified, if those problems are identified, versus the intrarenal. Because, once we have damage to, direct damage to that renal tissue, you can't turn it around. So, sometimes with people with acute renal failure, you may see, improvement happen, but, when damage is done, damage is done, and it can be permanent. So, if we got to help identify the cause and then help get it turned around as quickly as possible. So there's 4 phases of the acute renal failure, and of course the first one is initiating, and that is when, we first identify, uh-oh, we got a problem. And so, we know that there's an insult that's occurred, and some signs and symptoms become apparent there. And so this begins when the insult occurs and ends with oliguria developing. So oliguria is the next phase. And that's when we start seeing those urinary changes. We see the urine output. Again, you may see sometimes 500 mLs or 400 mLs per day listed for oliguria. But we start seeing a drop in that urine output. The urinalysis will see cast, which is definitely not normal to see. Red blood cells, white blood cells, we'll see protein in the urine. We start seeing the patient have fluid retention, and so we, obviously refer to that as fluid volume excess. We will see those neck veins distended, jugular veins distension, edema, hypertension, heart failure. CHF is congestive heart failure, but we'll call it heart failure. Um, Also, pulmonary edema can occur, and pericardial and pleural effusion. So both effusion meaning there's fluid in that area, the pericardial area and in the pleural area. Uh, that's not supposed to be. We'll also see metabolic acidosis where the patient cannot synthesize the ammonia that's in the body, and so we start getting acidotic there. The bicarb decreases because the kidneys cannot reabsorb it like it's supposed to. We'll see signs and symptoms of that, the Kussmaul's respirations, that's done to compensate, to help blow off excess CO2, lethargy, and stupor if it's not treated. Sodium balance, the kidneys unable to conserve that, so we're going to see a high urine sodium level, whereas the serum level may be normal or low. And of course, if that's uncontrolled, if we don't get on top of that, that can lead to cerebral edema. And then we can also see an excess of potassium there because, again, the kidneys are not able to excrete it. And, of course, levels greater than 6, we can start seeing arrhythmias there. And, of course, patients can die from hyperkalemia there. Let's see, this part of the phase can last 3 to 5 days for children and 10 to 14 days for adults. So, sometimes when we see these patients come into the hospital, we may think that it's their heart's a problem or diabetes. We're seeing all these signs and symptoms. You may even think, it's a respiratory issue when in fact the culprit is the kidneys, or are the kidneys. And, again, with acute renal failure, the sooner we can get on top of that problem, identify the cause, and treatment started, the quicker the patient will recover. And that's why it's so important that we do our assessment on the patient, including the physical exam, doing a good history on the patient, a med history on the patient, reviewing those labs and x-rays so that we know what's going on with our patient. Additional things we're going to see, hematologic disorders, anemia, and that's because, we'll definitely see that with patients because remember that the kidneys produces that erythropoietin, and so that's what's used to make our red blood cells. And when the kidneys are impaired, so is this function, the erythropoietin production. Also, we'll see platelet abnormalities. So with that, when we don't have enough platelets, what are we at risk for in our patients? We're at risk for bleeding. And so we got to be watching about signs and symptoms of bleeding. Also, our white blood cells are altered for these patients as well. With calcium, we will see in the acute phase calcium deficit and a phosphate excess. So remember, calcium and phosphate, they're typically inverse, like the seesaw. If the calcium's up, the phosphorus is down. If the phosphorus is up, the calcium's down. So the reason why the calcium is down is because, again, another function of the kidney is to activate that vitamin D, and we have to have the vitamin D to help absorb calcium. And when we don't have activation of the vitamin D, we're not going to absorb our calcium. And so we're going to see a low calcium there. And we'll see a high phosphorus. So that's a typical thing you see with kidney patients, or at least with acute renal failure. Also, waste product accumulation. So we're going to see that BUN and creatinine elevated. We're going to see a decrease in the GFR, the glomerular filtrate rate. Now, you may see, on some patients that their output will be completely normal. And that when that occurs, so when we see that BUN and creatinine elevated and the GFR down, but our output is completely normal, then that is referred to as that non-oliguria form of renal failure. And that can occur with nephrotoxic agents and burns, traumatic injuries, and that kind of thing. That's why we got to look at the whole picture of patients. Also, neurological disorders can accumulate in the brain and the nervous tissue and cause seizures and a stupor, coma, difficulty concentrating, that kind of thing. So this is just a picture. I call these things pictograms. These, just showing you some causes of acidosis, and it talks about hypoventilation. It also talks about diabetes ketoacidosis, but it mentions there at the metabolic acidosis, the renal failure being the issue. So the top right is respiratory acidosis, but for kidneys, we're focused more on the metabolic acidosis. So with that, you're going to see a low pH and a low bicarb level. Here's a pictogram of the potassium hyperkalemia and just some signs and symptoms that you may see. Also, it shows you the EKG down at the bottom, the ECG. What you will see is when they're hyperkalemia, they'll have an elevated T wave there. So that's what we usually see with patients with the elevated potassium level. Now let's go to the next phase, and that is our diuretic phase. So we start seeing a gradual increase in that output, and usually we're looking at that. We call this phase when they get to 500 mLs, greater than 500 mLs per day, and so they can have as much as 1 to 3 liters per day, but the issue here is that it's not concentrated. And the nephrons aren't working if it's not concentrated. Okay, it's caused by osmotic diuresis from a high urea concentration in that glomerular filtrate, and the tubules are not able to concentrate the urine. So the kidneys recover ability to excrete waste, but they cannot concentrate the urine. So for this, if we're urinating 1 to 3 liters per day, we got to now watch for dehydration, hyponatremia, and hypokalemia, because when it comes out like that, a lot of urine, we're going to lose electrolytes there. So we got to be watching for that as well. In the recovery phase, we can look at this. They can be asymptomatic, but it can take several months to years to get back to normal. But we start seeing that GFR increase, and our BUN and creatinine kind of plateaus and decreases. And of course, we're going to, be checking urinalysis, specific gravity, BUN and creatinine, and scans, that kind of thing. Now, understand that, we may have some scarring that goes on. because of the renal damage. And, you know, that's not good when that happens. And, you know, again, sometimes patients will have permanent damage, but the kidneys are back to at least, um, you know, functioning uh, as well as they could. So, you know, that's going to be something that you're going to work with on your patient. So, prevention. Definitely there are things that we can do, guys, for prevention. And please know this, because this is something that our patients, they don't know these things. We know these things. And so we got to ID these patients who are at risk. This is crucial in our care. And so, you know, monitoring or reducing risk of certain procedures such as x-rays, watching about dehydration due to MPO status. I mean, I've seen patients, you know, who go in and take care of them and they're like, when am I going to ever get anything to eat or drink? And it's like, well, how long have you not had anything? For 2 days. 2 days? Oh, for goodness sakes, folks, we need to, if our patient is not being assessed and checked and progress of their care is not happening, we need to address that. You know, MPO waiting on a procedure or MPO waiting on surgery. Let's get fluids going. Let's get, you know, some stuff going here for the patient so we don't lead to dehydration. And because again, it can lead to renal failure. Medication administration. Look at those meds. Do we have nephrotoxic meds there? Are we monitoring that output, intake and output on the patients and those labs to make sure that there's not some kind of situation that can put the patient at risk, or that it's causing any kind of problems? That's why it's crucial that we look at those labs. Um, find out the patient's past med history and the medical history as well. What were their past surgeries and procedures? You know, did they have something that could cause scarring, that could have caused scarring? Um, you know, because if scars form in the the kidneys, think about what scars do to skin. You know, the flexibility of that skin is not there when scars form, right? So same thing, likewise in the kidney can happen as well. So take this serious. Our patients are counting on it. We want to prevent and treat shock. You know, if we got somebody hemorrhaging, hypovolemic shock, uh, septic shock, any type of shock, you know, is if it's hemorrhagic shock, if it's hypovolemia because they're hemorrhaging, we got to get blood going, we got to get fluid going. So we can play a big part in this, and I am passionate about, you know, us as nurses checking this. We got to watch about wound drainage too. You know, there's patients we have that have horrible wounds and they have tremendous amount of drainage. We've got to count that as a part of that output, because again, that can lead to dehydration and definitely burns. Um, infections, you know, we want to decrease those invasive procedures when we can. And of course, blood transfusions, watch for reactions there because, you know, patients can have reactions and that can affect the kidneys, and follow the procedure for checking out the patient. Okay, now let's talk about chronic renal failure. So these are some things that can um, lead to chronic renal failure. And if you talk with patients who are having to have dialysis, um, you know, probably 9 out of 10 of them are diabetics. And then the other part, the one that's not, is probably there because of hypertension. Because these things directly, especially if they're uncontrolled hypertension and uncontrolled diabetes, they can lead to chronic renal failure and lead to patients having to go on dialysis. Also, again, we talked about the glomerular nephritis, pyelonephritis. We talked about this list already. We can also see here any kind of collagen disorder, such as systemic lupus. Again, any kind of endocrine disorder that can definitely lead to chronic renal disease. So it involves a progressive, irreversible obstruction of the nephrons, and the stages defined based on the level of kidney function. The end-stage renal disease, or ESRD, is our last stage, and that's when our GFR is less than 15 per our GFR, our glomerular filtrate, is less than 15. The end result is, again, the systemic disease involving every organ. And, there's about 70,000 people that die from renal failure every year. Our stages with chronic renal failure, you'll see uremia, where there's an excess of that urea and nitrous waste in the body and the patient's blood. Polyuria can occur with chronic renal failure, and of course, with that, the kidneys can't concentrate the urine. Oliguria can occur, and anuria can occur. So here is a pictogram just showing some beginning phases of uh, insufficient renal function there. So our GFR, seems to be doing okay. And, we're watching that blood pressure, and um, may need to get a 24-hour urine for a creatinine clearance test to detect any kind of loss of renal reserve. And kidney damage with normal or increased GFR can occur. Um, Again, a decrease in our concentration of urine, and usually we'll see that at night. And then, of course, treatment of comorbidity conditions, other conditions, is going on. We got diabetes, hypertension, maybe some renal artery stenosis there where the vessels are narrow. And then we start seeing the renal insufficiency. So patients might complain of headache and things like that. Now, in your book on page 1528, chart 51, there are 5 stages of chronic renal failure. And I really don't want you to memorize that, but just take a look at it and see if you can make sense out of it. It starts off again that things may be looking okay. GFR may not be too bad, and may even be normal. But there has been some damage that's occurred. It progresses. Chronic diseases progress. And as it progresses, you're going to see that GFR going down. And, we'll see some mild anemia because, again, remember the kidneys, what they do. In addition to filtrating, uh, and reabsorbing what we need to keep in our body and getting rid of the waste, it also plays a big role in our red blood cell production. It plays a big role in our calcium and our electrolytes, our blood pressure, our potassium, all of that. So we're going to start seeing problems occurring with all of those things. So some mild anemia because of the erythropoietin. We'll see that increase in serum potassium because, again, the kidneys aren't excreting it. That's one of the wastes that's got to get out. Um, and, blood pressure issues, weakness and fatigue. Um, BUN and creatinine is going to be elevated. We'll start seeing that polyuria go to oliguria. So again, a output of less than 500 or 400, and again, decreased ability to concentrate that urine. In children, you'll see growth disturbances as well. Now, I absolutely love this picture because it just shows you how much of the body is involved when somebody has chronic renal failure. Chronic uremia, meaning urea is in the blood, and that's chronic renal failure when we have that. And so just look, every system basically is involved in renal failure, chronic renal failure. So every system there, and we're going to talk in detail about several of these, but you know, it's definitely an issue with the entire. It's a systemic condition here, isn't it? When you see every bit of this area happening. So let's talk specifically about some of the systems. We've got hypertension that's going to occur because of that sodium and water retention or from an activation of the renin angiotensin aldosterone system. Heart failure and peripheral edema from fluid overload can occur as well. Um, Peripheral edema can occur also because of the you know, we're retaining fluid there. We're going to have that jugular vein distension, JVD. Um, the other thing, let's see, I'll talk about that here in a minute. Let's see, hyperlipidemia can occur because of issues with our carbohydrates not being able to be synthesized. So we'll see a elevation in our fats, you know, triglyceride, cholesterol, that kind of thing. Hyperkalemia we talked about. Arrhythmias can occur as well. Now, reason being there, pericarditis can be due to uremic toxicity of the pericardial lining. And, you know, everything is uremic, the heart, the lungs, and so we're going to see major problems there. And pericardial tamponade is a condition that can happen. And that is where cardiac tamponade is a compression of the heart that occurs when blood or fluid builds up in that space between the myocardium and the pericardium. And so obviously the heart's not going to beat right, and it prevents the ventricles from expanding fully, and it cannot fill enough or pump blood. So it results in the tamponade arrhythmia there. And again, the pericarditis occurs as well because the lining around the heart has the uremia in it. With the integumentary system, we can see a gray bronze color of the skin. Pruritus is itching. The uremic frost is where literally you start seeing the poison coming through the skin. And that looks like they've got salt on them. That's what it looks like a frost. Um, Dry, pale skin, brittle hair, dry hair, nails. Petechia. Petechia is with dealing with their, and purpura. Both of those are dealing with their platelets. Okay, so when we have too little of platelets, we're going to see little small bleeding of the skin, little small areas there that's going to, you know, little red or purple places of the skin, and that is called petechia, and that means bleeding is occurring, and ecchymosis is bruising of the skin. When we look at the GI tract, we are going to see mucosal ulcerations that occur, and stomatitis where there's problems in the oral cavity there. Uremic vector is where there's a urine odor of the breath. Anorexia, nausea, vomiting, diarrhea, constipation. Also, you'll hear patients talk about a metallic taste in their mouth. And they can, you know, when we have any kind of ulcerations like that, we can see GI bleeding, gastrointestinal bleeding as well. And oftentimes these patients will complain of hiccups, having a lot of hiccups. Neurologically, lots of issues can occur, of course, level of consciousness and mental ability, the ability to stay focused and concentrate, that kind of thing. Confusion. Asterixis is where there's an abnormal muscle tremor uh, consisting of an involuntary jerking movement, especially of the hands, but it can be of the tongue or and muscle groups like of the foot, that kind of thing. Um, they can have seizures and coma where there's problems in the, pathology of the brain, and encephalopathy is talking about the brain. Peripheral neuropathy can occur. We can have, see people with the restless leg syndromes and burning feet. That's like early symptoms of that uremic peripheral neuropathy. They can have muscle twitching as well. They can become lethargic, apathetic, fatigue and weakness and irritability. With respirations or respiratory systems, we can see, the Kussmaul's respiration because of that metabolic acidosis, dyspnea, tachypnea, crackles, sputum being really thick and tenacious, pulmonary edema, uremic pleuritis. Remember, there uremia everywhere, so in that pleural space, it can be, uh, uremic there, and pleural effusion, meaning the fluids in the pleural area where it shouldn't be. Um, they are predisposed to respiratory infections for sure, and they'll have a depressed cough reflex as well as uremic lung. Anemia, again, due to that erythropoietin and bleeding tendencies because of platelet issues, and they can become thrombocytopenia, cyto being cell and penia being decreased, so thrombocytopenia. Also infections because they can have changes in those white blood cells as well, and their whole immune system is just totally messed up. And so they're definitely predisposed to infections, and they're going to have a diminished inflammatory response. So they're at high risk for infection here. Osteodystrophy for renal patients is a very interesting type of thing that happens. We'll see skeletal changes, and it's all because of that calcium and phosphate metabolism. And with end-stage renal disease, we'll see two different types of things that happen: osteomalacia and osteitis fibrosis, which is both meaning the weakening of the bones. Difference is the fibrosis, they can actually have deformity of the bone, but it means that it is weakened. The bones are weakened, and so it's pretty cool. Not cool. This is not cool at all. But it's fascinating to me at how the body tries to compensate here with this whole osteodystrophy. So let's take a look at it on this scale. With kidney failure, you see that decrease in renal failure, and we see a decrease in the excretion of phosphorus. So let's flip to the other side. With renal on the right side, you know that with kidney failure, they're going to have an activation, the deactivation of vitamin D, which will then impair the calcium's absorption, which will decrease that calcium absorption now, or the serum calcium level. So anytime our calcium level drops, our parathyroid hormone kicks in, okay, and tries what the parathyroid hormone does is it pulls the calcium from the bone to increase that serum level. That's where the PTH is what's related to that osteitis fibrosis. Okay, so we get a bone demineralization, meaning that because we don't have that calcium in there, the bone starts breaking down. That's what causes the osteomalacia. So we've got an elevated uh, phosphate level, and now we have an elevated calcium level. So most of the time, when it's not a renal failure patient, when we see an elevated calcium level, we're going to see a decrease phosphorus level, right? But in renal failure patients, we will see an increase in both when they get to this stage, in the chronic renal failure stage. Reproductive system, we will see issues there: infertility, decreased libido, sperm counts low, so amenorrhea for the women, so definitely issues there. With our metabolic disturbances, we're going to see obviously an increase in our BUN and creatinine. We're going to have nausea and vomiting, lethargy, fatigue. We kind of already talked about that stuff. We'll have altered carb metabolism, so that's going to mess with our fats. It's also going to mess with our insulin and how our cells or the results from cellular insensitivity to the normal action of uh, insulin. Retained substances, for sure, we're going to see urea, and these are things that we don't want to retain. Okay, these are things that we normally should be getting rid of, right? Um, Urea, creatinine, phenols, those are extremely poisonous solutions. Uh, it can be things from antimicrobials, anesthesia, uh, stuff like that. Hormones, uh, you know, electrolytes, water, hydrogen. Hydrogen is, retained because it's not being excreted. All of this stuff, basically, is not being excreted. And, that hydrogen is another, retaining that hydrogen is another issue with that whole metabolic acidosis as well. So, when we're hanging on to things that should normally go out of the body through the urine, we're going to have issues, big issues. With our urinary system, our urine is going to be lots of protein. We're going to have cast. Uh, Pyruria is pus, and possibly hematuria as well, blood in the urine. Electrolyte imbalances, we've already mentioned hyperkalemia, and that's probably our most serious one that we're worried about because it can cause the fatal arrhythmias. Again, it occurs because we're not getting rid of it. Our sodium, it can be normal or low. We're going to see that edema and hypertension and heart failure. We got to, be careful about that. Some patients may actually, have a low sodium and uh, water and become hypotensive. So we got to watch about that. Watch about vomiting and diarrhea as well, because we're obviously going to lose more sodium if that's is going on as well. Calcium and phosphorus, we already talked about that being an issue. And of course, metabolic acidosis, that's we've talked about as well, where that, you know, is going to be an issue. And main reason there is we're holding on to acids that we normally get rid of, primarily ammonia, and we're not reabsorbing uh, the sodium bicarb like we normally should. So our whole acid-base balance is messed up. Psychological changes can occur as well: withdrawal, depression, mood behavior, emotional issues, and that kind of thing. And then we get to the end stage, and that's where our glomerular filtrate rate is, 15 or below, or below 15, and we're going to see lots and lots of different signs and symptoms there that we have already talked about. I love those pictograms to kind of pull the data all together with you on one sheet there. And of course, these patients are ready for hemodialysis at this time, or some type of dialysis. And so a nursing care of patients with chronic kidney disease and acute renal injury, we got to assess these patients, assess all patients' fluid status, nutritional status, the patient knowledge. Do they understand how important it is to stay hydrated and, watching kidney function, that kind of thing, especially if they're taking nephrotoxic drugs. Also, self-esteem, working with the patients on that because they definitely may have issues with all of that. And then those potential complications. And those are your hyperkalemia, the pericarditis, pleural effusion, all of these things that are listed, bone disease, metastatic calcifications, anemia, hypertension, all of those things we want to try to keep under control for sure and treat and take care of, because that can preserve existing renal function, and we want to try to our best to prevent all of these complications to occur. So, interventions for sure are numerous when we're talking about these kinds of things, and all the things with chronic kidney disease, because of so many things that's going on with the patient. We got to monitor neurostatus, mental status, seizure precautions, fluid and electrolyte status. Watch for both hyper and hypo of these different electrolytes that we're talking about. Vital signs we're going to watch. We're going to watch their EKG or monitor their EKG. We're going to obviously check urine output and their weight, monitoring that. We're going to check about edema. We want an ABG to check for that acid-base balance. We're going to monitor for infection and monitor those electrolytes like we talked about. With the diet, most likely these patients will be protein restricted, increased carbs, and restricting the potassium, and sodium possibly. We may be administering meds, and they may be meds such as Kayexalate if their potassium is too high. Fluids during that oliguria stage. You may see your patient on a restricted fluid intake, so we've got to monitor that. Many times what they'll do is they'll say, okay, your fluid intake is going to be what your previous, is going to be restricted to what your previous 24-hour output was, plus so much, usually 500 to 600 cc's of insensible fluid loss. So if we've got to calculate that up of what the patient can have in a 24-hour period, we've got to have accurate outtake, output. And, so that's going to be important to communicate with your tech that's working with you or nursing assistant, so that we'll know an accurate amount of fluid restriction that's needed to be done. Again, we got to watch for infection, and eliminate any kind of invasive procedures if we can. We're going to listen to breath sounds and heart sounds. We're going to do so much, medication administration. We'll see things given here, possibly blood given to the patient as well. Possibly medications to prevent any kind of ulcers of the stomach. We know that the patient's going to be intolerant of activity. They're going to be tired and fatigued, so we got to monitor for muscle strength and check about that. Watch about their gait. Are they weak? Are they unsteady? We don't want to have a fall during this time. And we got to do tremendous amount of teaching for these patients for sure, so that they can manage this on their own at home. Nursing diagnoses of fluid volume excess, imbalanced nutrition, knowledge deficit, and of course risk for situational low self-esteem. That's just a few of them. I bet we could list 10 more nursing diagnoses with these patients. Our planning is we're going to, work towards, getting them at their ideal body weight. That's what the IBW stands for, without the excess fluid, and maintain the adequate nutrition and knowledge, increase for sure on how to do self-care there. And obviously we don't want to have complications. Here are things that we can do with our excess fluid volume. Again, assessing for those signs, keeping an accurate I-NO and daily weights, limit fluids to that prescribed amount, identify those sources of fluid, and explain to the patient about fluid restriction, why it's going on, and help the patient cope, and obviously provide frequent oral care, because when you're thirsty, your mouth gets dry, that kind of thing, you have a yucky taste in your mouth. And we already talked about some of the metallic taste and that kind of thing that occurs as well. Nutrition, we've got to definitely assess the status there, weight changes, the labs, we've got to look at all that. What's their pattern, their history, what do they prefer? So what foods they can eat, we want to have those available for them. And, again, staying within that prescribed diet and fluid restrictions as well. Needs to be high quality, nutritious foods. And stomatitis and anorexia, we got to watch about that, because, anytime the oral mucosa is inflamed there, it's going to be difficult for them to eat certain foods, any kind of spicy foods, anything that's very hot or very cold. We just need to work with the patient on that. And then last, assess the patient and family's response to the illness, because this is a big, big diagnosis for individuals, and there's a lot of empathy that needs to be expressed. There are a lot of resources out there for patients, so finding those, but being able to work with a patient to work with them and help that family cope with this situation. Okay, that concludes this part of the podcast.